Morning, everybody. I'm Rob Hartzler with San Antonio Orthopedic Group. I'm going to talk to you about Remplissage this morning. So I'm going to go through when to do Remplissage and how, some historical indications for Remplissage. This is a murky area in the literature, so Matt Provencher wrote up a nice review article on a classification and treatment algorithm for Hill-Sachs lesion. No classification system is really accepted for Hill-Sachs lesions. And when you look at surgical indications for these, there's a lot of, like I said, murky area, hand waving, and a big gray area in terms of deciding when to treat these. So let's say you've decided to treat a Hill-Sachs lesion. There are a lot of options of what to do. You can go to open Bankart and really over-tighten and over-constrain the anterior soft tissues. You can go to prosthetic replacement, osteotomies, things in red that are sort of bad that we don't do very often. You could bone graft that area. You can go to Labral and increase the arc length to exclude that lesion, and you can do Remplissage. So rationale for Remplissage, filling in that lesion with the posterior cuff and capsule. It's an arthroscopic technique, no allograft needed. We've seen really good success rates in the literature, both short, midterm, and long-term, and not too many complications. One con of Remplissage is that you can lose some external rotation doing this, especially with larger lesions. So looking at the results of doing arthroscopic Remplissage, if you look at a systematic review, 6 studies, 167 patients, low recurrence rate, really a fairly low, although external rotation wasn't reported in all these studies, a fairly low decrease in external rotation and overall good outcomes with low complications. So when I was in training, one of my mentors told me, how do you decide when to do Remplissage? Well, it's like salting soup. You know, you just start fixing stuff, and if it seems like you need some more, then you just add Remplissage in. So, and that's not wrong, but if you want something more scientific and more rigorous to hang your hat on, we also don't want to be over-treating our patients either and adding Remplissage when it's not necessary. So a couple of new ideas that have become really important for me. This idea of subcritical bone loss. So if you look at highly active patients in the military population, for first-time dislocators, if you just do a Bankart repair, even for patients who didn't sustain a recurrence of their instability, a lot of them don't have good shoulders. So if you look at the WOSI score, which is pretty rigorous in terms of looking at their functional outcome, patients with bone loss that we might not have thought of as that critical actually don't do very well. So this doesn't tell us what to do. Should we do Labral? Should we do Remplissage? Another idea that's really important is the glenoid track. So if you take cadaver shoulders and put them in the position of apprehension and abduction external rotation, the glenoid makes this imprint medially that's about 84%, 83, 84%, with a big error bar depending on the laxity and the compliance of the soft tissues onto the humeral head. So this can allow you to start to quantify when lesions are going to engage. So the importance of this is that if the Hill-Sachs lesion does not extend medial to the glenoid track, then engagement isn't possible theoretically in that situation. Whereas if the Hill-Sachs lesion is medial to the glenoid track, where that glenoid is having that medial imprint, then engagement is possible. And really critically, if you have glenoid bone loss, that shortens that glenoid track a lot. So my partner, Dr. Burkhart's been popularizing this idea of using a fairly algorithmic approach for deciding when to add Remplissage based on lesions being on track and off track. And the advantage of doing this is that you can do this based on calculations and that you don't have to test after you've already done repairs whether engagement's happening. So in this algorithm or this paradigm, for the first decision point that you make is whether you're going to go right to Labral, which is we've written is based on greater than 25% glenoid bone loss, and then treatment of the Hill-Sachs lesion with Remplissage is based on whether the lesion is on track or off track. So this is fairly straightforward to calculate. You have to know the intact diameter of the glenoid, how much bone loss there is, and then you just do this simple arithmetic. And once you know how what the width of the Hill-Sachs interval is, then you can just compare the glenoid track to that. So this is a right shoulder arthroscopic view from an anterosuperior portal, and you can see the bare spot there. So the intact posterior diameter of that's 15 millimeters. So that means that the complete radius with no bone loss is 30, and then the anterior radius is 10, so we've lost 5. So we'll have those numbers to plug in. And then measuring our Hill-Sachs interval, this is a 4 millimeter end of the probe, so it looks like 3 widths there of the actual Hill-Sachs, and then 3 probe widths for the bone bridge in between the cuff and the Hill-Sachs lesion, for a total of 12 and 12 is 24. So we just do this math, 30 times 0.83, subtract out the bone loss. That gives us our glenoid tract, which is about 20, and then the Hill-Sachs interval was 24. So the Hill-Sachs interval bigger than glenoid tract means that that lesion is going to engage. So it's pretty theoretical. So is this paradigm valid? So again, if you look at the military population retrospectively, if you just do bank heart repair for those patients and look at who has recurrences, off track is actually really highly predictive of people who are going to have recurrent instability. So the positive predictive value of off track is 75% in this study. So we should do something more than bank heart repair for off track lesions. But it doesn't tell us what to do. So thank goodness Ty Lee's here, so he can, if anybody has questions about this, he can explain this to us. We went to his lab and studied what happens in a biomechanical model of moderate glenoid bone loss with on-track and off-track lesions. So what we found in this study was that, as predicted, with on-track lesions, engagement of that, both just putting the arm into the apprehension position and testing it translationally, was very rare. But with an off-track lesion, engagement was routine. Bank heart repair was sufficient for restoring stability for on-track lesions, but remplissage was required to restore stability for off-track lesions. So remplissage really increases the stiffness of the joint construct, of the repair construct in off-track situations, as you might expect. But what's interesting is even for on-track lesions, you get a significant increase in joint stiffness, especially when you bring the arm back into that apprehension position for on-track Hill-Sachs lesions. It's interesting if you read the methods of these kind of biomechanical studies, like our study. It's amazing how much damage it takes to create a dislocating shoulder. So if you take a cadaver shoulder and make sort of what you would think of as a standard bank heart lesion, there ain't no way that thing's dislocating. So in this study, we have a posterior capsular split, so we can get back to do our Hill-Sachs work and the remplissage. There's an extended bank heart lesion from 12 to 6 o'clock. We made our glenoid osteotomy, an anterior split in the capsule. That thing is still not dislocating. You have to force it out then. And so shoulders that have instability problems, I agree with Kevin. You look for damage and repair it, and that's how you get good results with these patients. So new techniques for doing remplissage. So I'm going to talk to you about a knotless technique. So these are figures from our new cowboy book. So this kind of knotless anchor technique allows you to do a double mattress without tying any knots. And basically what you do is place 2 knotless suture tacks, or you can use the knotless corkscrews when those come out if you don't have good bone quality. And you thread the working suture back into the splice from one anchor to the other anchor, and then pull tight. And so you don't have to tie knots up in the subacromial space. So here's just a quick demo of that. This is Paul's case from the book. This is left shoulder. So we're going to see a quick shot of the bank heart lesion there, and then you can see back on our Hill-Sachs lesion, we're going to come through with the percutaneous insertion kit and place 2 anchors there at the margin of the Hill-Sachs lesion. Sometimes that angle of approach isn't the best, and you actually have to come through the posterior portal and then re-grab those sutures at the correct angle through the capsule and through the tendon. Up in the subacromial space, you can see that we're going to grab the working suture from one of those anchors and thread it through and thread it back into the other anchor, using the passing suture from the second anchor, and then going back and doing the same move for the second anchor. And so if we pull on those, that's going to bring that capsule and cuff down into the lesion there. So we had a chance to study how these knotless anchors perform in the lab. I had a bit of a jaundiced eye about these when they very first came out, but they're amazing actually. So if you compare in foam blocks, a medial double pulley technique, knotted versus knotless, this is essentially the same in terms of displacement with cyclic loading. Clearly that's not going to be a clinical failure, just over 1 millimeter of displacement for both of those. And then if you look at how do these do creating a clinical amount of failure, actually the knotless construct here in this Remplissage type of model outperforms the knotted construct. So in conclusion, for Remplissage, when you're considering treating a Hill-Sachs lesion, we really think that this on-track, off-track model is going to be the future, and that's something objective that you can hang your hat on so that you're not under-treating or over-treating these patients. But consider adding Remplissage for certain situations, even if it's on-track, such as poor capsular tissue or high-demand patients. And this knotless technique is quite handy in terms of efficiency in the OR and from a biomechanical standpoint. So remember the glenoid track, it's arithmetic, not calculus. You can do it. Thank you.